Histopathology of rejection in reference to ABO-incompatible transplant. So this was, I thought I'll discuss with you uh, the renal pathology in ABO-incompatible transplant and how it is different from routine conventional transplants. So when I say that the histopathology in ABO-compatible transplant, the main reference will be to thrombotic microangiopathy because that is the dominant finding you see in ABO-incompatible transplant whenever a rejection occurs. So before I start with ABO-incompatible transplant, just I want to show you some images how in a routine conventional transplant looks like. So what are the morphological findings based on which we say that yes, we are looking at a acute AMR. So when there is diffuse ATN, there is diffuse acute tubular injury. So what you see here are tubules which are back to back, but they are dilated. Okay. So there's a hyper magnification to highlight that this is a distal tubule where you can see the nuclei, these blue looking cells. These are the tubular nuclei. This is the lumen. As compared to this distal nuclei, just look at the distal tubule, just look at the proximal tubule. So proximal tubule has got brush border. So in this case of AMR, what you can see here is if you follow this tubule, you can see the tubular nuclei at this area, but there is complete loss of tubular nuclei in this focus. Okay. In addition to that, now we come to this second tubule. So in this tubule also, you can see the tubular nuclei here, but then there is some destruction of the tubular nuclei and there is shedding of the tubular cytoplasm into the proximal duct lumen. So sometimes the ATN could be, so this the first image was showing ATN predominantly a mild kind of ATN where there is just dilatation of the tubules. But but there are areas where the tubular necrosis or tubular injury was very significant, very severe. So there are different kind of terminologies in histopathology we use. Uh, one group of nephropathologists will say that this is acute tubular necrosis. The other group of nephrologists, they prefer terminology of acute tubular injury than acute tubular necrosis because they say acute tubular necrosis in by terminology acute tubular necrosis, that means there has to be necrosis of the tubular epithelial cells. But majority of the ATNs which we come across in native or transplant biopsy, you don't see necrosis of the tubular epithelium. Necrosis of the tubular epithelium is seen in very severe kind of acute tubular injury or acute tubular necrosis means that there has to be necrosis of the tubular epithelium, which happens mostly with severe ATI or severe acute tubular injury. So they are synonymous, but the thing is, we prefer using a terminology of diffuse acute tubular injury rather than acute tubular necrosis. But yes, that is a common terminology, ATN, so you label it as ATN. It doesn't change anything, but you have to remember there are two types of ATN which we mostly talk about. Either it is a toxic ATN or it is a ischemic ATN. You have to remember in AMR, the ATN majority of the times will be very severe. That means there will be necrosis of the tubular epithelial cells, or in other words, it will be acute tubular necrosis or severe ATI, severe acute tubular injury. So in this case, what I'm showing in this image is there is severe kind of acute tubular injury or acute tubular necrosis, where there is you are seeing some tubular nuclei which are showing necrosis, and there is sloughing of the cytoplasm in the tubular lumen. So whenever acute tubular injury is there or acute tubular necrosis is there, mostly it affects the proximal tubules. So first thing to go is proximal tubules, where there will be initial stages, there will be loss of brush border, and subsequently you'll see tubular necrosis also. Now this in compared to this distal tubule, it is not showing any changes. So distal tubule is absolutely fine. So the other finding you see in a acute AMR occurring in a conventional transplant is you see thrombotic microangiopathy. So what you're seeing is in the glomerulus you are seeing these kind of pink stuff which is there in the glomerular lumen, and there are cells also. So these are neutrophils which are lying in the glomerular capillary lumen. So that means when you see cells in the glomerular capillary lumen, that means it is glomerulitis. The terminology in transplant biopsy, we label it as glomerulitis. On the other hand, in a native kidney biopsy, when you see neutrophils in the glomerular capillary loop, you label it as endocapillary proliferation. But in transplant biopsy, you label it as glomerulitis. So what you're seeing is some capillary loops are showing this kind of a fibrin kind of pink stuff, and some capillary loops is showing microvascular inflammation or glomerulitis. So here also you can see some one occasional neutrophil in this lumen. There is lymphocyte here, and in this you can see 4 to 5 cells. Okay, so there is glomerulitis along with thrombotic microangiopathy. Some occasionally, not occasionally, I would say that in acute AMR, sometimes the AMR is so dominant that you see mostly majority of the glomeruli showing fibrin thrombi. So in this, you can see this is the glomerular capillary loop. These are the RBCs. So there are congested glomerular capillary loops. In addition, the remaining glomerular capillary loops are showing fibrin. Okay, so this is glomerular changes of acute AMR, where you find TMA, where you find glomerulitis. In addition to that, you'll find PTCs. So this is a peritubular capillary in between the proximal tubules where you see significant neutrophilic peritubular capillaritis. So when I say neutrophilic peritubular capillaritis, when I say neutrophilic or lymphocytic glomerulitis, both these terminologies are clubbed together as microvascular inflammation. So in conventional transplant, you are going to see microvascular inflammation. That means glomerulitis, neutrophilic peritubular capillaritis. In addition to that, you can see in the tubular interstitial compartment, acute tubular injury or a very severe kind of acute tubular necrosis. And in the glomerular compartment I have shown you, there could be thrombotic microangiopathy also. So these are the classical findings you see in acute AMR. In addition to that, the interstitial blood vessels may show transmural arteritis. So this is a vessel which is showing neutrophils and lymphocytic infiltrate, which is causing destruction of the vessel wall. So this is called as transmural arteritis, or in other words, this is a severe kind of vascular rejection. So what you see here is you can see the endothelial cells and there are lymphocytes beneath this endothelial cells. In addition to that, the lymphocytes are also infiltrating the tunica media or the smooth muscle layer. That means there is a transmural kind of arthritis which is occurring. So whenever we see transmural arthritis, there are only two differential diagnoses. First is acute AMR. The second differential is it could be a very severe kind of acute T cell mediated rejection. But yes, whenever you see transmural arthritis, think first of acute AMR. So, how to differentiate acute T cell mediated, severe T cell mediated rejection from acute AMR? Because in acute T cell mediated rejection, you are going to see interstitial infiltrate also. You are going to see tubulitis, which is not seen in the images which I've shown you. So, it is showing only acute tubular injury, TMA, glomerulitis, peritubular capillaritis, and the vessel showing transmural arteritis. So, it is a combination of all these findings along with diffuse C40 positivity. So, we have to remember one important thing. Many cases of acute AMR, you are not going to see C40 staining. C40 could be negative also. So morphology plays a significant role. So if on morphology I see all the three things, there could be that all three things will be there, or there will be one or two things which are there. It is possible that there is ATN, along with that there is TMA, or there is a vascular rejection. On the other hand, there is a possibility that you see all the classical morphological features of acute AMR. That means TMA, glomerulitis, peritubular capillaritis, ATN, and diffuse C40 positivity. So absence of C40 positivity doesn't mean that it is not acute AMR. Okay. So in a classical case of acute AMR, all this will happen, which I've shown you. So C40 can be done by immunofluorescence, which I'm depicting here. That this is a direct immunofluorescence where you see glomuli, which are showing staining of the glomerular capillary wall, as well as there is diffuse staining in the peritubular capillaries. So the staining of the peritubular capillaries, that is the most important thing. Okay. So I don't know how to remove this. Okay, go. So C40 can be done by immunohistochemistry also. So majority of the centers where there is only one modality as well, because I do C40 by both the methodologies, C40 immunofluorescence as well as by immunohistochemistry. But there are many centers who are doing only C40 by immunohistochemistry. The advantage with immunohistochemistry is that you need only single core, and you need not have two cores. On a single core, you can do the routine morphology as well as you can do C40 immunohistochemistry and SP40 immunohistochemistry if required. So in this case, so C40 was positive by immunofluorescence as well as C40 was positive by immunohistochemistry. Yes, immunofluorescence is a better methodology than immunohistochemistry. You have to remember that. Now I come to ABO-incompatible transplant. How the morphology in ABO-incompatible transplant, the rejection morphology, dominantly acute AMR, is different from morphology what you see in a conventional transplant. So just a brief introduction about this thing. So it will be a case based. I'm going to show you. ABO and HLA incompatibility is considered as an important immunological barrier for renal transplantation. We all know that with the advent of effective preconditioning protocols, it is now possible to do renal transplant across ABO barrier. And there are preconditioning protocols, which you all know, rituximab, plasmapheresis, IVIG, and you maintain immunosuppression with tacrolimus, mycophenolate, and prednisolone. The interesting part is, whatever I know about little bit after discussing with you all people, that you start CNIs 1 week before in ABO compatible transplant whereas in conventional transplant I think you start on the day of transplant or a day prior. So that means these patients who are ABO compatible, they are exposed to CNIs for a longer duration as compared to conventional transplant. So what happens is, so I'll show you this case and then you will understand. So this was 45-year male with end stage renal disease who underwent a live donor ABO compatible renal transplant. Recipient was B positive and donor was A positive. Donor was wife, and for preconditioning, rituximab 200 milligram followed by 2 sessions of plasmapheresis and IVIG to decrease the anti-A titers from 1 is to 64 to 1 is to 8. Tiger titers for our center. So this was a case which was done in I think 2012 or 13 in Medanta, and tacrolimus was 0.05 milligram per kilogram per day, and mycophenolate was started 1 week prior to transplant. So pre-transplant, the CDC and flow cytometric cross-match was negative, and this patient received 2 doses of basiliximab. So post-operative period, there was initial diuresis. However, 6 hours after surgery, urine output dropped, and color Doppler flow imaging showed no evidence of arterial or venous thrombosis. So in view of persistently low urine output, despite adequate fluid resuscitation, re-exploration was done. Graft was turgid with normal anastomosis, and a wedge biopsy was taken. So this was a wedge biopsy on the day of surgery, and this is what it shows. So a good number of glomuli they were fine, except for if on this magnification I can say that there was some expansion of the urinary space which can occur due to ischemic injury, but this glomulus which I'm pointing, this was at low magnification, this was looking more red as compared to other glomuli which were looking fine. In addition to that, this glomulus also was looking very full of something, whether it was fibrin or what, it was looking more pink or more red as compared to other glomuli. So I'll show higher magnification of these glomuli. So this is a higher magnification. You can see some of the glomuli, like this glomulus, this is absolutely normal. But these two glomuli, they are the capillary loops are full of they are filled with fibrin. So there were fibrin thrombi in the glomerular capillary loops, and in this glomerulus also there was a segment which was showing fibrin thrombi. In addition to that, the tubules were dilated. There was evidence of diffuse acute tubular injury. So in this case, morphologically there is TMA, but this TMA is not affecting all the glomuli. It is affecting few glomuli because this was a wedge biopsy. So wedge biopsy, you can see 100 to 150 glomuli also. So this was a good wedge biopsy. There were around 100, 150 glomuli, but there were only 10 to 15 glomuli which are showing these fibrin thrombi. So it was not like a diffuse TMA affecting all the glomuli. But we need to understand one important thing. We did this biopsy on POD0 on the same day of biopsy. Okay, on the day of transplant. The other glomuli were fine, and there was some diffuse acute tubular injury. This is Mason's trichome stain. So Mason's trichome stain highlights fibrin thrombi as fusionophilic or red color deposits. So you can see these red color deposits in some of the glomuli. So this glomulus is also very red looking, but just compare this glomulus with this glomulus, which is not showing any fibrin thrombi. This glomulus is also showing a lot of red stuff. And this glomulus, only one segment is showing more red stuff and somewhere here, but this segment of the glomulus is absolutely fine. So TMA was affecting few glomuli, and in some glomuli, all the glomerular capillary loops were affected by TMA in form of fibrin thrombi, but in some glomuli, the TMA involvement of the glomerulus was very segmental, as you can appreciate here. In addition to that, there was diffuse acute tubule injury because the tubules are separated now. There is separation between the tubules. That means there is some interstitial edema and the tubules are dilated. This is another high magnification of the same glomerulus with fibrin thrombi. So you can see the glomerular capillary loops are filled with this kind of fibrinous stuff. Okay. So sometimes you can confuse them as hyaline thrombi also, which you commonly see in hyaline thrombi. You see in lupus nephritis, cryoglobinemic glomerular nephritis. But yes, this is the morphology you get to see here. But when you do Mason's trichome stain, just see, you can see threads in these glomerular capillary loops. So that means when you see thread kind of a stuff, that means it is fibrin. So it is not cryoglobulins. So cryoglobulin will not appear, at least on microscopy, routine microscopy, as it will not show those kind of fibrin threads. So there was lot of fibrin threads. So it was thrombotic microangiopathy which we're looking at. This is another, there was one glomerulus which was showing mesangiolisis. This is just for comparison. I have shown on the left side, you can see a normal glomerulus where you can see the capillary loops. You can see a mesangium where these blue looking nuclei are there. So that means in a mesangium, normal mesangium, you can see 2 to 3 nuclei and never more than 4 nuclei. So if there are more than 4 nuclei, you think more in terms of mesangial-proliferative kind of morphology. So just for comparison, you can see this glomerulus here, which is showing capillary loops. There is mesangium, supporting mesangium. But when the mesangium is gone, that means there is mesangiolysis. So mesangium is like a supporting medium which supports all the glomerular capillary loops. The moment there is mesangiolysis, there is just destruction of the mesangium, all the capillary loops will get dilated and they will appear congested. So there is no mesangium. That is why all the capillary loops are dilated. There is no supporting medium which is there. So presence of mesangiolysis also suggests there is acute thrombotic microangiopathy. The interesting part is in this biopsy, the wedge biopsy, the vessels were fine. There was no evidence of any glomerulitis. There was no evidence of any peritubular capillaritis. So what I want to highlight is there is no microvascular inflammation. So in absence of microvascular inflammation, there is ATN and there is TMA, which is affecting few glomeruli. C40 was negative in peritubular capillaries. As you must have known this fact that accommodation is a process which occurs in a ABO-incompatible transplant and C40 is mostly positive. But C40 will take some time to develop. It will not happen on the first day. So if mostly it takes at least 2 weeks, sometimes 10 days for C40 to be positive in a ABO-incompatible transplant. So this was POD 0 and C40 was negative in the peritubular capillaries. Now, there is, I won't say diffuse, but yes, wherever the glomerular involvement is there, it is significantly diffuse kind of involvement. So there is diffuse glomerular thrombotic microangiopathy with severe ATN. Okay, and what are the possibilities you can think of? So the possibility we can think of is whether it is a CNI induced HUS-TTP or CNI induced TMA, because we have to remember one important thing. TMA is a morphological diagnosis. So based on morphology of TMA, it is impossible to say whether this TMA is due to drugs, whether this TMA is because of AMR, or whether this TMA is because of some infection, or it is a de novo HUS or TTP kind of a TMA. The only thing is the supporting evidence in favor of acute AMR in conventional transplant is that you get to see microvascular inflammation. You get to see C4D positivity, which you will not see in a de novo HUS-TTP or CNI-induced HUS-TTP. So in the present case, there was no microvascular inflammation. C4D was negative. See, so the possibility thought was, so that is why the first differential was it is a CNI-induced HUS or TTP or CNI-induced TMA. The second possibility whether it is recurrent or de novo HUS or TTP. The basic disease in this patient was not HUS or TTP, so that possibility was bit less likely. But yes, de novo HUS TTP can occur, or it was acute antibody mediated rejection. So on POD1, there was drop in hemoglobin from 10.7 gram per deciliter to 7.7 gram. Platelets reduced from 1.2 lakhs to 50,000. And peripherous smear showed cystocytes. And biochemical evidence of hemolysis was there. Tacrolimus trough levels were 22.3 nanogram per ml. So obviously the tacrolimus levels were very high. We thought that this is CNA-induced TMA, and in this patient, the tacrolimus was stopped. NTA titers remained 1:4 post-operatively. DSA was negative. So we have to remember one important thing in a ABO-incompatible transplant. Somehow, The titers, they don't correlate with the histopathology. What you see, you may see a histopathology where there is severe TMA, and uh, there is a graft nephrectomy also which is being done because the TMA has progressed to cortical necrosis, but the titers will be fine. So somehow the titers don't correlate with the histopathology findings. So you have to go with what the histopathology shows. So histopathology, if it shows TMA, you have to, even if the titers are normal, you have to think of TMA due to CNIs or TMA due to AMR. Those kind of possibilities you have to keep. And even the DSA is mostly negative in majority of these cases. So anti-A titers remained 1:4 post-operatively. DSA was negative. This patient received 5 sessions of plasmapheresis. There was a delayed graft function requiring dialytics support, and a repeat biopsy was done just to understand whether the TMA has progressed further or whether there is reduction in the degree of TMA. So this was the second biopsy, and the second biopsy showed there was acute tubular injury. You can see these dilated tubules which are there. There was no interstitial inflammation, so no evidence of acute cellular rejection. Even the glomuli, they look pretty good. So the glomuli was not showing any evidence of TMA in the present biopsy, except for and occasional glomulus where the glomerular hilar vessel was showing a segmental TMA. See, as compared to the first biopsy, wedge biopsy, there is significant reduction in the TMA. The ATN was more or less the same. There was no significant reduction in the degree of acute tubular injury, and that was the reason that this patient was dialysis dependent. But the TMA was significantly better. This is a high power magnification of the same glomulus. So in this biopsy, there was only one glomulus which was affected and which was showing a very segmental TMA, and it was not like a diffuse TMA. C40 was again negative in the second biopsy. So it was patchy glomerular TMA with acute tubular injury. Uh, so clinical course after second biopsy, dialysis was stopped. Serum creatinine came down to 3.1. He was switched to cyclosporin and steroids were continued. So POD fourth week, there was a non-colicky epigastric pain and recurrent non-bilious vomiting. Upper GI endoscopy revealed deep round punched out hemorrhagic ulceration involving esophagus and corpus of stomach. And this is just not related to renal pathology, but this biopsy showed uh, mucormycosis. You can see there's a broad non-septate hyphae of mucor which were there because obviously ABO-incompatible transplants tend to they are heavily immunosuppressed, and in addition to that there was some large cells also, so we did CMV stain also which was positive. So it was a combination of in mucormycosis and CMV infection. So blood blood CMV viral load was 2200 copies per ml, and liposoma amphotericin B and ganciclovir was started, cyclosporin was stopped, CT abdomen showed pneumoperitoneum, and dissection and urgent exploration laparotomy was done with distal gastrectomy, and condition progressively worsened and patient succumbed to uh, because of immunosuppression. So we published this case. So what I want to highlight is in this case, if we talk about renal pathology, the renal pathology was consistent with the CNI-induced TMA. When we stopped CNIs, yeah, obviously we gave plasmapheresis also, but there was morphological evidence to suggest that this was possibly related to CNIs, and this was not acute AMR related TMA. So I'll show you one more case. So in this case, this was ABO-incompatible renal transplant, blood group A to O. There was discoloration of graft on the table, and anti-A titers were 1:8. So in this biopsy, there was ATN which was there, but majority of the glomeruli they were showing this kind of a pink material. So here also you can see, and so majority of the glomeruli they were showing this kind of pink material, and this was like 40 minutes after placing the graft, the biopsy was done because there was some discoloration. And when we go to high magnification, you can see these fibrin thrombi. In addition to that, there was some neutrophils also which were coming in. Okay, so in addition to thrombi, there was some neutrophilic glomerulitis also. There was diffuse acute tubular injury. Yes, the tubular injury was not that severe. So it was ATI only and not tubular necrosis. You can see the tubular nuclei which are well preserved in majority of the tubules. The tubules are dilated, and there was you can see the brush border here. So there was some disruption of the brush border here and there. So there was a mild kind of acute tubular injury. But yes, if you look at the PTCs, the peritubular capillaries, only RBCs are there. So there is no peritubular capillaritis. C40 was negative. Uh, we gave a possibility that this is TMA in view of occasional glomulus showing neutrophilic glomerulitis. Though the C40 is negative, we thought that it could be AMR, it could be CNI induced, both the possibilities we kept, and even recurrent HUS or TTP. Because this TMA was more severe as compared to the first case which I showed you, which was focal TMA. So this TMA was affecting majority of the glomuli. Uh, so plasmapheresis, everything was started. A second biopsy was done 12 hours because the creatinine was rising. So the second biopsy shows the ATN, which was very mild. So you can see here in the on the upper hand, you can see these tubules which are preserved, but in this in this area you can see there is significant tubular necrosis. So just compare these tubules with the tubules which are lying here. So there was significant kind of acute tubular injury, and the TMA was of similar degree, which I showed you in the first image. So TMA was persisting, and the ATN also progressed further. So it was the ATN was progressing towards more severe kind of ATN or acute tubular necrosis. Now, the second biopsy, which was done 12 hours post transplant, so it started showing a very minimal kind of C40 staining here and there. It was not diffuse, but there was some minimal staining in the peritubular capillaries, which I am showing here. This is just for comparison. So we did IHC also on these on both the biopsies. So 40-minute biopsy was showing no staining in the peritubular capillaries, but the biopsy done 12 hours, it showed C40 staining in peritubular capillaries. So that means there was, this could be accommodation, but you have to remember that accommodation will take some time. It is like 12 hours post transplant, and you are seeing C40 positivity. So a third biopsy showed cortical necrosis. Okay, that biopsy was not done on 28 days, so it was done prior to that. But then it showed cortical necrosis, and then we got this graft nephrectomy specimen. So despite starting plasmapheresis on time, on the day of transplant, so this TMA progressed further, the acute tubular injury progressed, and we lost this graft. And the graft nephrectomy showed all the classical findings what you see in a acute in a antibody mediated rejection. So you can see you appreciate the vessels which were very thick. I'll show you here. So in the graft nephrectomy, we appreciated there was a lot of microvascular inflammation, a lot of peritubular capillaries. These are the PTCs. They were showing a lot of cells. So there was significant peritubular capillaries, but yes, it was not visible in the initial biopsies, three biopsies which I have shown you, and it affected mostly the vessels. So vessels were badly affected, and the glomuli were showing TMA, and the vessels were showing significant narrowing. You can see this lumen is completely narrowed. This has progressed from acute to chronic AMR because you can see this intimal sclerosis now setting in. Another vessel showed necrosis of the vascular endothelium. Similarly, this vessel is also showing complete necrosis of the vascular endothelium. In addition to necrosis, there is fibrosis also which have set in. So there are thrombi which are formed within the vessels. So there is complete occlusion of the vascular lumen. So we have to remember one important thing whenever uh, so C4D was positive, so diffuse cortical necrosis, because majority of the areas were necrotic, and I have clicked images only from few of the viable areas. So this was consistent with the antibody mediated rejection uh, because C4D came 12 hours post transplant. There was diffuse TMA. The acute tubular injury was also very severe. So based on these findings, we suggested that this is possibly acute AMR and not CNI induced TMA. So we published around there was 20 ABO incompatible renal transplants which were performed, and everything went fine. Our first paper which came in Indian Journal of Nephrology, so this went on fine because there were all these 20 transplant went absolutely fine, and suddenly the 21st 22nd and 23rd ABO-incompatible transplant. They landed up in a acute AMR stage, and we had to do graft nephrectomy. So you don't know in ABO-compatible setting which patient will land up in a AMR kind of a scenario. So this was just that total number of patients, 36 transplants were done, and there were C40 staining pattern. And because initially when we started doing ABO incompatible transplant in Medanta, when I was working there, so we were doing protocol biopsies, and because these were the initial stages of starting a nephrology team starting the ABO incompatible transplant. So indication biopsies had to be done, but there were protocol biopsies also which were done. And since the transplant program was running on very well, we stopped doing those kind of protocol biopsies because everything was going smooth. But as I've told you, so initial 25 or 26 transplants were fine, but suddenly then there were 2 3 transplant. Subsequently they landed up in a graft nephrectomy kind of a stage. So C40 staining pattern, if I just want to highlight here is, so total number of biopsies with C40 positivity was 18 out of 32. So around 56.2% of the patients transplant biopsies were C40 positive. So that means the accommodation majority of the 60%, around 60% of the ABM compatible transplant will show C40 positivity. It is not like 100% of biopsy will show C40 staining. But we have to remember one important thing: early post transplant, if you see C40 positivity, you have to think that it is possible, and you are seeing on morphology there is TMA, severe TMA with all those severe acute Doppler injury. Think of acute AMR as one of the possibility, because early post transplant C4D should not be there. So early, over the years I have seen that if C4D staining is seen in early first 1 week in a ABM compatible setting, think more of acute AMR than CNI induced AMR, than a CNI induced TMA. So there were 36 patients, 21 biopsies were done, protocol biopsies 7, normal histomorphology in 3, donor-related changes in 2, suggestive of CNI toxicity in 1, there was 1 inadequate biopsy. So indication biopsies 25 were done in 14 patients, 13.8% turned out to be acute cellular rejection. AMR was seen in 8.3% cases. Now all these 3 cases, they landed up in a graft nephrectomy was done in these cases. CNI toxicity to TMA in both these cases. So we have to remember that there was recurrent C3GN in one of the AVM compatible transplant who presented 3 months post transplant with nephrotic range proteinuria, and the basic disease was also C3 glomerular nephritis. Uh, to conclude, what I want to highlight is the C40 staining is it does not correlate with the histological changes suggestive of acute AMR. So isolated C40 staining in peritubular capillaritis might reflect the state of graft accommodation, but the finding needs to be carefully interpreted in some patients. So if there is an isolated C40 staining, this could be related to graft accommodation. But if there is a histomorphology which shows that there is TMA, diffuse TMA, there is severe ATN with or without microvascular inflammation, you have to think that it could be related to acute AMR. So C40 positivity in the first week post-transplant is likely pathological. So I'm not saying 100%, but the thing is, if your morphology also supports, histomorphology supports that this could be acute AMR, so this positivity could be likely pathological. And we have to remember that TMA is a dominant finding in AMR associated with ABO-incompatible transplant. And microvascular inflammation is not commonly seen, because the thing is, microvascular inflammation somehow, we have seen biopsies of AMR in a ABO compatible setting. Microvascular inflammation is never a dominant finding. You get to see microvascular inflammation when the graft nephrectomy is done, but on a routine biopsies you don't get to see microvascular inflammation that dominantly. The other thing I want to highlight is that there were occasional cases in which uh, 3 4 biopsies in a ABO compatible transplant was done. I remember there was one case in which early post transplant there was TMA, and somehow that TMA recovered, and by plasmapheresis and everything. And then after 6 months, again there was rise in serum creatinine. So serum creatinine never came down to baseline, never touched baseline, but it was towards the higher side. But every time the biopsy was done, so the second biopsy was done at 6 months, then there was a repeat biopsy which was done at 9 months. Every time the biopsy was done, C40 was positive. That was because of accommodation or AMR, whatever the reason. Because if it is positive 2 weeks post ABO-incompatible transplant, it is impossible to say whether it is due to accommodation or whether it is due to acute AMR. But the dominant finding in all the 3-4 biopsies which was done was TMA. There was no microvascular inflammation, but we lost that graft 1 year post transplant. So that was the only biopsy. That was the only case of ABO compatible transplant, which uh, in which graft nephrectomy was not done in the first 1 week or 10 days post transplant, because somehow we were able to save that graft by plasmapheresis and all that. But majority of the time, if you see AMR, acute AMR, first 1 or 2 weeks post APO compatible transplant, those AMRs are so severe, they lead to severe kind of TMA with cortical necrosis that you are not able to save them despite starting plasmapheresis on time. Even if you are able to save, so which I told you one such case, the TMA remains somehow. And what is the cause? So there are a lot of speculations that why, and majority of the graft nephrectomy, the DSA was negative at the time of graft nephrectomy also. At the time of cortical necrosis also, DSA was negative. The titers were absolutely within normal range. So titers, they don't correlate. DSA also is majority of the time negative. So whether these are some anti-endothelial antibodies which are causing this injury and which are not picked up in the routine immunological workup, whether these are causing that cancer, we are not very sure about that. But yes, that could be the probable explanation, because in avian compatible transplant, the endothelial injury is the most dominant pattern of injury you see, as compared to conventional transplant where you see more of inflammatory kind of injury. That means microvascular inflammation. Yes, along with that, there is some endothelial injury which is there, but in ABO compatible setting, it is dominantly a severe endothelial injury which causes the graft dysfunction, which leads to graft rejection and graft loss. So I don't wish to discuss about the C3 glomerulonephritis post-transplant. So my aim was that you should get this message that C40 first 1 or 2 weeks post-transplant ABO-compatible setting could be pathological. And the second thing is TMA is the dominant finding. You see in AMR associated with ABO-compatible transplant, and microvascular inflammation is not commonly seen in ABO-compatible settings. And it is because you start CNIs early, so CNA-induced TMA is a very close differential diagnosis, which you have to keep in cases of ABO-compatible transplant. So TMA could be due to CNS, could be due to acute AMR. These are the most common two things which you have to keep. But as compared to the conventional transplant, if you find TMA early post-transplant, your first diagnosis always is it is acute AMR. But in a ABO-compatible setting, you think of CNA-induced TMA also as one of the strong possibility. Okay, so I am done with my presentation. So if there are some questions, so I can take those questions now. Hello. Hello. So if there are no questions, so Puneet is there.
Yes, sir.
Yeah.
So actually, Mr. Puneet is not here. I'm his colleague from marketing.
Okay. So are there any queries from the participants, or they have understood everything?
Still not going to get any message.
So they can put in the chat box also if there are. Need more frequent classes, sir. Okay. So this you can request to Dr. Kher and Dr. Jha. We can have more frequent classes related to renal pathology. So remember one important thing in a ABO-incompatible transplant, you don't get to see that kind of a chronic AMR because majority of the graphs, if you lose that graph, you will lose because of acute AMR only. So somehow they don't progress to a stage of chronic AMR. Even when they progress to chronic AMR, it will be only chronic TMA you will see. You will not find that kind of the microvascular inflammation, the glomerulitis, and all that stuff. So, are there any questions? So, if there are no questions, should we stop here? So, majority of the students are first year students or they are in their final years?
Sir, second year students.
Second year students. Okay, fine. So, was it too much for you? I have taken some routine, a basic renal pathology class for you people, or this is like you are attending for the first time?
Not sir. I attended this for first time, sir.
Okay, you are attending for the first time. Then it is a bit tough for you because the thing is, I thought that there will be final year or kind of students. So I thought I have taken few classes beforehand also for routine kind of basic renal pathology. So next time maybe I can do a basic kind of renal pathology class also, which includes all the special stains and how does a globulus looks like and all that stuff. I thought majority of you are senior, so I thought I'll discuss ABO. You must be doing ABO compatible transplants routinely in your organizations. So you come across these cases of AMR or graft loss because of AMR in a ABO compatible setting.
Yes, sir. Yes, sir.
So your good name is who is answering? Doctor
Anvesh. Dr. Anvesh.
Doctor Anvish.
Anvesh. Yes, sir.
Okay, so you work in which hospital?
Sir, I am from Vedanta only.
Oh, you are from Medanta only. Okay,
Yes.
okay, fine.
But the last year I was not able to attend your class. One class I for few minutes I was able to attend because in offline classes you were not able to go.
Okay, fine, fine. So the thing is, ABO incompatible. So I remember a majority of these cases are when I was with Dr. Vijay K's team. So majority of these cases are from that thing. So this was early when we started doing ABO incompatible transplant. So this was our experience, initial experience. Initial experience was good, but suddenly, as I told you, there were 2, 3 cases suddenly, and you don't know which case will land up in a graft nephrectomy. So there are a lot of theories. So there is one group, Japanese group, which say that there could be complement abnormalities, which leads to because of which some patients are prone for endothelial kind of injury as compared to other patients. But there is no proven fact. So some say that you should get the complement levels done before any patient undergoes a ABO incompatible transplant. But I don't know whether you people you routinely do C3 complement levels before ABO compatible incompatible transplants. And are you doing any center is doing protocol biopsies in ABO compatible transplant?
Good evening, sir. I'm Dr. Ramya from Artemis Hospital.
Hi.
Uh,
Yeah.
Hello. No, sir. As of now, we are not doing any protocol biopsies in the ABO-compatible transplants.
Okay. 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 So we started we were doing some protocol biopsies, but somehow everything was fine in those biopsies, so we stopped doing that. But I think uh, we don't know that if early kind of TMA can be picked up on these protocol biopsies. We are not sure about that. So nobody has done protocol biopsies in a ABO compatible setting. So we are not sure about that. Yeah. And somehow, you have any experience that, because I don't exactly remember that, because they say that if you give, if there is a donor to recipient A group to O group, then the chances of rejections are high. Is there any studies on that which suggest that if this blood group is given to that recipient, so the chances of AMR is higher in those kind of blood groups? Any suggestions? So, Dr. Mohit, okay, if there are any further questions, so I can address those questions. Otherwise, we stop this meeting. So I assume we should. Uh, I am leaving this meeting. Thanks a lot. Thanks a lot. And if
Thank
there
you,
are
sir.
any,
Thank you so much for.
okay,
Thank you, sir.
so okay,
Nice class, sir.
okay, sir. Thank you. Bye bye.
Thank you. Thank you, sir.